Thank you and welcome. My name is Holly Brown, board-certified clinical pathologist. I did my training in the United States. I received my veterinary degree from the University of Georgia. I went into small animal practice and then returned to the university to complete my residency, stayed on for my PhD, and in a faculty position there at the university. I then transitioned to a unique role as a clinical pathologist to be in a point-of-care setting. So I joined a general referral and emergency hospital as an on-staff clinical pathologist. So a unique opportunity for me to deliver my expertise patient side and collaborate with the other doctors and nurses at the hospital around our most critical cases. I then joined Antech as their chief veterinary educator a little over 3 years ago, and still consult to the practice that's next door. So what I've done today is I've put together a series of cases, right? I've titled this, When You Need Critical Insights and You Need Them Now, Important Tips to Maximize Laboratory Diagnostics. And we'll just walk through some advanced cases. We'll focus first on the erythrogram, go through the leukogram, and then the thrombogram. We'll be pairing that with cytograms from their in-clinic analyzers that are generated. We will look at advanced testing available through the reference lab. We'll look at some images from blood films, urinalysis, etc. So let's start with our clinical cases. The first case I have is Paxton. Paxton's a 1-year-old male intact boxer, and we met Paxton many months previously when he was about 3 to 4 months old. He had been referred to our hospital with what ended up being a steroid-responsive meningitis. So he presented with a lot of pain. He would scream out in pain and some inappropriate mentation, and really traumatic for his family who had recently purchased him from a breeder and had him only home for a few weeks. So he came to our hospital on referral. He fortunately treated quite quickly in response to immunosuppressive doses of steroids. But then he became what we say a frequent flyer at our hospital, meaning he'd come back for frequent rechecks. We would see him, we would run lab work, make sure no untoward side effects of being on these high doses of steroids. If he was doing well clinically and no clinical signs of return of the meningitis, we would taper his steroid dose and see him again a few weeks or a month later. Now, at this particular visit, now he's a year old, and he's been off of his medication for about 2 months. The owner is presenting with Paxton, as well as there's another boxer sibling at home who's about 5 or 6 years old who was due for their annual exam. They had said, since we're here anyhow, we'd like to transfer our routine care to your hospital, and could we get Paxton up to date on his vaccinations? So remember, when he was referred to our hospital, we were not his first opinion hospital, and we were not managing his preventive care. So we had discontinued any vaccination, which makes sense, right, given that he was going to be on immunosuppressive doses of steroids and dealing with an autoimmune disease. So at this point, having been off medication for several months, totally normal clinically, mom is really happy with how he's doing at home. He looks healthy. He's very active in the exam room. He and the other boxer actually just wrestling in the exam room really the entire time. Looked like a picture of health. And at that point, they said, sure, no reason we couldn't get him up to date on his vaccinations. Except when they started his physical exam, they noted that his gums were really, really pale. And so this is totally unexpected given his activity level in the exam room and mom not appreciating any clinical signs at home. And if you look, this is actually a picture of Paxton. This is, again, after he's been wrestling in the exam room for 15, 20 minutes. And maybe you can appreciate that the pinna of his ear there is still very pale. Around his muzzle, it's really pale, right? We would expect those to be really bright pink given his activity level. So we're concerned, of course, for what appears to be a very significant anemia. We talked to mom about our concern, who's now equally concerned. This is so unexpected. And we talk about starting with looking at a CBC and a blood film to understand his apparent anemia. So we ran his CBC in clinic on the element HT5, and we'll show the results here, but focusing specifically on the erythrogram and looking at the data as presented through HealthTracks, the online portal for data. We'll start with looking at his red cell mass, and indeed, whether we're looking at the hematocrit, the hemoglobin content, or the total red blood cell count, we notice that he is indeed anemic with a hematocrit of 11%, right? So pretty profoundly anemic. And then we use the rest of the measurements here in the erythrogram, these red cell indices, to further describe that anemia. The first one we see there is the MCV, the mean cell volume. So that's saying of all of the red blood cells he has in circulation, right, the millions of red blood cells per microliter, are the appropriate size? And in this case, no, right? The mean cell volume is low, so we call that microcytic. The next one is the MCH that's listed. The MCH is the mean cell hemoglobin content. And that really does not deliver additional information that helps us diagnostically because smaller cells will have less hemoglobin. So it really doesn't add anything more, and you can omit that from your review. The next measurement is the MCHC, which is the mean cell hemoglobin concentration. So that's saying regardless of the cell size, is the concentration of hemoglobin appropriate? And in this case, we see it's low, right? So we call that hypochromic. So if we were to describe his anemia, we'd call it microcytic and hypochromic. And that pattern of microcytic hypochromic anemia is consistent with iron deficiency. Okay, that hypochromia, right, is saying decreased hemoglobin content because it's the hemoglobin that delivers the color to the red blood cell. So hypochromia, low color, right, because of less hemoglobin, and it's iron that binds hemoglobin. So that's how we understand that iron deficiency. Also noted here is this RDW percentage. So this is a more recently reported measurement, and I think it was added to a lot of our analyzers without a lot of education. So those who have been out of school, this may be new to you. This RDW, it stands for the red cell distribution width. And so by that, we mean it's the degree of red cell anisocytosis or cell size variability. So we take a healthy dog blood film and we look at the red blood cells in here. They vary in size mildly, right? And the RDW in this case of a healthy dog is at 12.6%, right there within the reference interval. But if we take a case here where we have IMHA, right? So we have immune-mediated hemolytic anemia. So we have some small spherocytes. We have some normal-sized red blood cells, and then we have some larger ones, right? Those larger bluer cells are the young red blood cells, right? The polychromatophils, part of that regenerative response. And given that variability in red cell size, the RDW is increased, right? Far outside the reference interval. And so I draw your attention to that because the RDW does not get outside the reference interval very commonly. It's a reasonably wide reference interval, and we're talking about millions of cells per microliter, so it's fairly tolerant of normal physiologic changes. When the RDW is high outside the reference interval, that really should prompt you to look at a blood film. Something is really different, off, pathologic with your red blood cells, and it's something you should be able to see. There's either a bunch of larger ones, a bunch of smaller ones, or maybe both. So when we look at Paxton's blood film, we appreciate here is that RDW. First, I'll put these asterisks on the small, medium, and large one, right? So all in a row there, we appreciate that increased anisocytosis or red cell size variability, right, from the get-go. And so while there is not a micrometer on there for us to measure size exactly, and maybe you wouldn't even know what a red cell size would be in health, note that he has red blood cells the size of many of his platelets, right? And so that's a really small red blood cell. Dog red blood cells should be much bigger than their platelets. They should not overlap in size. And so seeing that really small red blood cell shows us that microcytosis that was reported, small red blood cells. Now also note, if this is an average red blood cell here, note that the central pallor should be about 1/3 of the diameter of the cell, right? So if we measure across there, that area of central pallor where, the red blood cell is a biconcave disc, right? And the hemoglobin content is a lot less in the middle, right, where the two biconcavities meet. So it looks very pale in the middle. And again, that area central pallor up to 1/3 of the diameter in health. But if we look at Paxton, right, the majority of his red blood cells have increased central pallor, right? Increased central pallor, less staining, hypochromia, right? So microcytic hypochromic anemia, right, that's visible either on the blood film, we can appreciate it in the cell morphology, or through looking at the erythrogram, right? Microcytic, low MCV, hypochromic, low MCHC, and anemia. So when I think of my differentials for iron deficiency anemia, right, how this happens is so rarely is it because they're not getting enough iron in their diet, right? So most of our commercial diets, will have plenty of iron in them. And even those feeding ones that are non-commercial usually have meat in them and have enough iron for them. So that's usually not the problem. It's usually that we're losing iron from the body, right? And so when we lose iron from the body, we lose it quickly. They present with clinical signs of the anemia, right? So without any clinical signs, remember, he is well adjusted to his hematocrit of 11. He was bouncing around the exam room and mom noticed no problems. So what could cause a really slow loss of blood that would be undetectable to the owner, as it was in this case? Well, in an older dog, we think of a focal GI tumor, something like a gastrointestinal stromal tumor, right? A more diffuse GI neoplasia like lymphoma, right? They'd present for their systemic clinical illness that would result, right? Or the lack of absorption, right? In the GI tract. So a focal tumor is possible when it ulcerates through the mucosa, right? It would be dripping blood through there, right? Continuously. In a younger dog, we think of GI parasitism, and in particular hookworms, right? This is a common cause for chronic GI blood loss in young dogs. Now, in this particular case, right, I don't think that the clinician believed that a hookworm infection in this 1-year-old dog, right, could get his hematocrit down to 11%. He was more concerned of two possibilities. One, before we saw the lab work and the blood film, that maybe he had developed IMHA, given he had already had one autoimmune disease, and now he was off of all of his immunosuppressive medications, but it did not support that. He was worried about internal bleeding, and he had put the ultrasound probe on the abdomen and flashed the chest as well, and did not appreciate any accumulation of fluid to suggest blood loss into the body cavity. So he entertained us with running a fecal flotation, and we chose for the fecal to do the flotation in clinic first, right? Because we needed some answers now. And on that fecal flotation, indeed, he was loaded with hookworm ova. And so at the time, there was a lot of reward, I think, for me as the clinician who had sort of doubled down that this really should be his diagnosis, right? But that quickly turned to a feeling of regret, right? A little bit of remorse, because when we think about him having these loaded with hookworm ova, right, in his stool, we look at the life cycle and what's happening with hookworm infection, right? So I'm looking at a CDC image here, and the dogs or cats who are infected are shedding those ova into the environment, right? Well, they're going to hatch into their infective larval forms, right? They're going to reinfect Paxton, right? At risk for reinfecting the other dog in the household, right? But also at risk for infecting the people in the household, right? This is a zoonotic disease. And so we quickly realized that he's shedding lots of ova into the environment. This may have been happening for a while, right? There was some chronicity to it to get his anemia down to 11%. And if we think about the why, right, it's because we had discontinued his routine preventive care. We know that many puppies have hookworm infections, right? They're common throughout the world. And this is why we do routine deworming and fecal exams multiple times during puppyhood. But because he had transferred his emergent care to us, right, they had discontinued their visits with their regular veterinarian. And so they discontinued deworming, right, unfortunately, in his puppyhood. In addition, we immunosuppressed him for months, allowing this infection to grab a toehold, right? So we needed to make sure we got treatment right? And there are some challenges we have now with hookworm treatments, in that we're seeing some multi-drug resistance, right, to our typical drugs that we use for deworming, right, classes of drugs that we use. So they've identified, I think now, 2 different markers for benzimidazole resistance, right, in our hookworms. And it started initially recognized in racing greyhound kennels in the southern United States. But now it's been reported that they've been testing for this 72 different dog breeds, right? And of the cases that they're seeing that have positive hookworms in their fecal tests, 11% have this resistance marker, right? It's much higher than we initially realized. And since being found throughout the United States and southern Canada, right, we've also had it reported in Brazil, Australia, New Zealand, more recently India. And as it turns out, probably any place we do increased sensitive testing for this marker. So the testing that we can do to identify this treatment resistance is with the Keyscreen GI Parasite PCR panel. And so it's really a novel way of looking for GI parasites, right? So historically, we did fecal flotations, right, routinely. And if we think about that, when we're screening for GI parasites, we're really only screening for a small subset of parasites that can affect the GI tract. Right, we're talking about nematodes, right, that shed ova intermittently. So it's an insensitive means, right, for looking for GI parasites. and it does not sample the diversity of what could be infecting them. So for us to be able to tell an owner, right, that we see no sign of GI infection, parasitic infection, we need to be more thorough in our screening. And luckily, we finally have adapted a test to take PCR that's more widely available in the commercial space and apply it to fecal testing, right? So now we can do an expanded panel. This has 20 different GI parasites, a much more thorough investigation of the GI tract. And so when there is detection of ancylostoma or hookworm infection, right, they will check for a resistance marker, right? So one of those two markers, and it's consistently adaptable, right? It's now we have genetic material from these parasites when detected, and so we can add on different markers as they are detected. And in Paxton's case, they did not find the resistance marker, thankfully. We'll also add an additional benefit of having this genetic material that we're testing for. So not only is it very, very sensitive in detecting these GI parasites when it's shed, right, some in the feces, but additionally being able to do the additional diagnostics allow us for something like Giardia infection to investigate for zoonotic potential. So we know with increased sensitivity of detection, we will get increased positivity. And it can be a challenge with Giardia, right, worldwide, when we get positive infections to know if we need to treat or not, right? And we also want to be judicious with our antimicrobial use, right? So we may say in a totally asymptomatic pet where we detect a Giardia infection, we find out if it has zoonotic assemblages. And if it does not, and the patient's asymptomatic, we may elect, right, to not treat that and be, again, judicious with our antimicrobial use. So we could use a routine deworming protocol for Paxton. People have asked before if we transfused him, given his hematocrit was so low. We elected not to, given that he was not clinical for that severe anemia, right? He had had slow protracted blood loss over weeks to months, right, to get his hematocrit down that low and show that microcytosis and hypochromia. We did, however, add a multivitamin that had some iron in it, right, to help replace what we could through the parenteral route, and then repeated CBCs to assess his response. So we trended his hematocrit. If we look here on the graphic, that gray box is the reference interval. We see historically that his hematocrit normally runs at 42-41%. We see in this particular visit in August is where it dropped down to the 11%. And it took him, we checked him at 2-week interval, first of all, when he was coming back in for his deworming again. And he had already doubled his hematocrit, so we felt we were on track. But it did take another month and a half for him to finally return to his normal hematocrit. The next case I'll talk about is Sammy. So Sammy is a 7-year-old male-neutered Labrador, and we had met Sammy years previous to this. So when he was 3 years old, he had developed Lyme nephritis, right? So it's something that an infection that we see it's not common in the United States, but Lyme disease is really common, right? So Borrelia burgdorferi is the infectious agent. It's a tick-borne disease, right? Many have probably heard of Lyme disease. And we have only a small subset of dogs will have clinical signs of Lyme disease, right, of infection. And only a small subset of them will develop this sequela of a protein-losing nephropathy. But it's almost always fatal when they do develop it. We see it more commonly in our retriever breeds. So he had developed Lyme nephritis. He was referred to our hospital for further workup. And they did some investigatory treatment where they did intrarenal stem cell injections to try to help recover those kidneys. It actually worked for him. So he was our first patient to recover using intrarenal stem cell injections. So they started intrarenal initially, and then they became IV stem cell injections as the kidneys were recovering. And the owner also noticed that his arthritis was much better when he was receiving those IV stem cells. So even after the kidneys had long recovered, they would come in intermittently for repeated stem cell injections to help his arthritis. So he had come in 5 days previous to this visit for a stem cell injection for his arthritis. We had done lab work when he came in, and everything had fallen nicely within the reference interval. Everything looked healthy. He felt fine. He got his IV stem cells and went home. Normally, we would not hear from him again for months, right? But they called 5 days later to say he's acutely lethargic and anorexic. And this is him in the hospital, and obviously seeing a lab who's just hanging out on the floor in treatment is never a good sign. On physical exam, he was febrile at 104.7 Fahrenheit, and he was, as you can see, reluctant to stand. And we look at a CBC from 5 days previously. As I said, everything falls nicely there within the reference interval. We can appreciate on the right-hand side of the data that we have the visual reference intervals, right? Where we have the dark black marker in there in the middle, which is the patient's value. And there's the markations on the low end and the high end of the reference interval to show that everything fell nicely there within the middle. Everything was totally normal. Now, 5 days later, when we're rechecking it, there are a few subtle but significant changes. So we'll focus first on the leukogram. So if we look here in the leukogram, we'll start with noticing that he has a lymphopenia and an eosinopenia, right? Decreased lymphocytes and decreased eosinophils. When we see that pattern, that is a stress response. And so not a stress response of excitement, right? Not a physiologic excitement, but a stress response of illness. And this is mediated by glucocorticoids. So when the body is dealing with a significant illness, the adrenal glands will secrete more cortisol, right? In response to that, we see lymphocytes will redistribute into the tissues, less in circulation, and less eosinophils released from the marrow. So it's a really good sick patient test, right? Recognizing this as a patient withstanding a significant illness as Sammy was. I put asterisks by the numbers for the lymphocytes and the eosinophils because we have to be careful that those low end of the reference intervals run really, really low. And so not always in these dogs or cats with the increased glucocorticoids do we see them actually flag low. Sometimes they're at the low end of the reference interval. And so it is helpful, again, to look at the visual reference intervals on the right-hand side because you'd still recognize the pattern if they both trended at the low end of the reference interval. Also draw your attention to the fact that he has no leukocytosis or neutrophilia. And as a matter of fact, less than 50% of cases with known inflammatory disease will have this classic inflammatory leukogram. So we're taught that in school is how we're going to recognize inflammation, right? But it turns out in practice, it's not always going to pan out this way. We'll talk about it more in the next case. In truth, though, in recognizing inflammation, we would focus on the presence of bands. And again, we'll talk about more in the next case. So when we look at his CBC changes outside the leukogram, there's a significant change here that we'll note in the erythrogram. And this is probably a newly reported measurement for many of you. And it's the reticulocyte hemoglobin, right? In this case, it is low. So when we have analyzers like the HT5+ that we have available through Antech, right? It measures reticulocytes. And we talked about looking at hemoglobin concentration in red blood cells in general, right? And it's an indication of iron availability, right? But if we look at the hemoglobin concentration within reticulocytes, our young red blood cells, is a very sensitive measure of the current iron availability to the body. So it's either abbreviated retic HGB or RHE, right? Those both mean the same thing. They're looking at the hemoglobin concentration of that young red blood cell population. And it is a sensitive indicator of iron availability. And it may be, if we look in this graphical depiction, you'll see on the left side there just showing iron and it's in the plasma, right? And so we generally get it from the GI tract, right? And then it goes into our stores. It's available to the marrow, right? Following that top arrow. And then it's available for when we go through hematopoiesis and erythropoiesis to be put inside the red blood cells, right? The iron in the red blood cells is going to bind the hemoglobin, which binds the oxygen, which is the whole point of the red blood cell. Right? So it's a critical component, right, of building those effective red blood cells. So we see they're available in the reticulocytes, the young red blood cells. They mature through their normal maturation and then their senescence. When they get to the end of their life, as they've gone through circulation, they'll get phagocytosed by macrophages, the red blood cells will, because that iron is such a critical component, it gets recycled, right? So the iron gets recycled back into the plasma, then available to the bone marrow anew. So if we have absolute iron deficiency, which would come from blood loss, right? So loss from the body, less is available to the bone marrow. So the red blood cells that are made in the face of that significant blood loss, those young red blood cells, reticulocytes, will be lacking their total iron availability, right? And the total hemoglobin. So there's an absolute iron deficiency, but what becomes more important and exciting to me is recognizing a relative iron deficiency. And so to understand that, I have another graphic here. In the face of intense inflammation, right? The body does a really cool thing. This is across all mammals. So in the face of intense inflammation, our macrophages secrete a lot of cytokines, right? And one of those cytokines is IL-6. Interleukin-6 is available. It circulates, it creates things like fevers of illness, right? The other thing it does is it goes to the liver and it causes production of the acute phase proteins, right? And one of the acute phase proteins is hepcidin. And what hepcidin does is that it's going to, this is really neat, it's going to do a couple things. It's going to block the export of iron from those macrophages. So the macrophages are going to sequester the iron from those senescent red blood cells, right? It's also going to block some of the absorption, right, of iron from the GI tract. And the reason the body's doing that in the face of this intense inflammation is actually that iron is necessary for any microorganism to survive as well. Right? Every living cell is going to need iron for their replication and survival. And so the body's thought is that in the face of intense inflammation, if we sequester iron and there's less available in the plasma, then this infectious agent won't thrive. Right? So it's a way of sort of starving that infectious agent. Now, it's just a temporary thing, right, during that infection. So that's not really deleterious to the body because within days, as the fever subsides, the infection gets under control, we'll release that iron, we'll absorb more from the gut, and the body really doesn't show the difference, right? Just a couple of days of having some of that iron restriction. But what we will notice is we look at the young red blood cells that were made during that period, right, of iron sequestration. They will show that low iron availability and that low hemoglobin. So measuring that hemoglobin content in the reticulocytes is a very sensitive way of detecting the iron deficiency. And it really looks at the functional iron over just the past couple of days. So in the face of infection, as we see with Sammy, right? So I'll tell you that he does have inflammation given his fever, right? And his discomfort, but we see that he is sequestering iron. And so his reticulocyte hemoglobin is low, which makes us wonder about an infectious agent. And so we'll also see here in the thrombogram that he has reported thrombocytopenia. So his platelets are reported at 81,000, and I draw attention to any reported thrombocytopenia because I think that we've become a little numb to reported thrombocytopenias in practice, meaning that we write them off very frequently to assuming that there's platelet clumping in our sample, right, given how common that can be. But I think in not doing our due diligence to follow that up means we risk recognizing or we risk missing, right, true thrombocytopenias, which can give us some really important insights, right, into underlying pathology. So the first thing we do when we see a reported thrombocytopenia is we must exclude platelet clumping, right? We don't want to just assume that it is there. And depending on your analyzer, you'll see cytograms like this, right? And so these cytograms will give you insights, right, into thrombocytopenia and platelet clumping. And so learning those cytograms from your analyzer, whether it's the histogram on the left, right, or that scattergram on the right, they can show you sometimes overt platelet clumping. And so if you see that, right, then you know you do have platelet clumping. It's a quick scan, right, to look at those cytograms when you learn them from your analyzer, right? And then you know if you need a more accurate platelet count, you'll have to do a redraw. Right? But assuming you don't see evidence of platelet clumping in your cytograms, and of course the traditional way to look for platelet clumping is making a blood film, right? We're obviously going to look on the feathered edge, right? And then we want to make sure we don't see any of these large platelet clumps, right? Which we can see in Sammy, he had none. So to perform a manual platelet count, so assuming you have no true platelet clumping apparent, then a manual count can be performed. It's done with a microscope at 100x oil, right? And I show a calculator there, right, for calculation, although who uses a manual calculator anymore? People are probably on their phones. Equation that we can use here, right, is taking the average number of platelets per 100x field, right? So at 100x oil, right, and what is the monolayer of the blood film, meaning the red cells are starting to abut each other, but they don't overlap. It's where our best cell morphology and cell counting is. So we take the average number of platelets per one of these 100x fields. So start at one field, move to the next adjacent one count, move to the next adjacent one count. Ideally, you'd go over 10 fields and divide it by 10, but I probably get a little anxious after like 5, then I get restless. And so I'll just do my calculation there. But if I take my average over 100x field, multiply by 15,000 if it's a dog and 20,000 if it's a cat, right? So using this equation, you can determine the total number of platelets per microliter. And it's a crude estimate, but it'll help you bucket, right, to understand if we are in the area of a thrombocytopenia that's verified, right, if you're somewhere within the reference interval, right, or if you're extended beyond that in a thrombocytosis. So here's just some practicing. So if we look at this anemic patient who's also may have a reported thrombocytopenia or maybe marginal, and you want to do a count. If we're at 100x, we'd circle here, right? We can see the platelets here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And if that became your average over multiple fields of looking, you would take that count of 10, multiply it by 15,000, because we're looking at a dog here, and that would give us 150,000 platelets per microliter, right? And so if you want to do a little cheat, just know that generally 10 to 20 platelets per 100x field should roughly get you into the reference interval, right? Which makes sense, because if it's 10, then it's 150, and double that would be like 300,000, and that's roughly a healthy reference interval for a dog. And multiply by 20,000, it's a cat, a little higher from a cat's appropriate. So in Sammy's case, and looking at his blood film review, when we look at his platelets, right, we only have 2 per this field, right, the 700x field that we see. And so because of that, we can verify he truly has a thrombocytopenia. But more importantly, we're actually seeing something else in here, right? So I'm zooming in here so you can appreciate what we see here, right, with the arrows. And those are rickettsial moruli, right? So those are 2 rickettsial moruli, which are evidence of tick-borne disease. What's happened here is the body's been tick transmitted, been infected with bacterial cocci. That bacteria has been engulfed within the phagosomes of the neutrophils, right? Or any of our phagocytic cells. And then within the phagosome, it's multiplying. And so then you get the multiple little dots in there that have that mulberry-like appearance, right? And so that having that mulberry-like appearance, it then shows us that that means we have tick-borne infection. It's not always 2 moruli like I have here, right? Sometimes it's a single one, and probably more commonly it's a single, but this is the example I've shown because it's so dramatic. So when we see rickettsial moruli, specifically in our granulocytes, meaning in our neutrophils or our eosinophils, it's either Anaplasma phagocytophilum or Ehrlichia ewingi. Those are the 2 species that we see within our granulocytes. So you might find this interesting, when we perform a vector-borne disease serology testing, right, that we have available at point of care or at the reference lab, note that he has no antibodies to any of the tick-borne diseases, right? So if we think about what these screening tests, right, are used for heartworm, we're looking at an antigen, right? We're looking for active infection, right? But for the tick-borne diseases, we're looking for antibodies like exposure, right, or infection. And it's saying negative, even though I have evidence, right, based on that blood film. And that's because, well, I think if we think about Lyme disease, right, and so something that maybe some of you have some experience with, depending on where you have lived, right, with Lyme disease, as I said, when we see dogs with Lyme infection, we see them in a chronic state when they're showing clinical signs of disease, right? For people, we get erythematous bullseye rashes, so we get to see the acute stage, but we don't appreciate that in dogs. So by the time we're seeing clinical signs, they're chronically infected. And if you were to check their vector-borne serology testing, we would see that they do have the Lyme antibodies, right? But we have to be careful around acute Ehrlichias, and in particular Anaplasma, right? Because we see them in the acute phase, right? They present differently, right? Ehrlichia ewingi can, and certainly Anaplasma phagocytophilum. And so they don't have those antibody titers yet when we see clinical signs. So if we look at this graphic from the CDC, you'll appreciate those the first couple weeks of infection, right? Serology testing is not the appropriate test to do. That doesn't turn positive until, strong enough positive till 2, 3, maybe even 4 weeks later, right? And will stay high for a while, right? So in truth, it's PCR testing that's best to do to actually look for the infectious agent in the blood, not the immune response in those first couple of weeks or during acute infection. And as a matter of fact, when we think about using this vector-borne disease screening that's serologically based, right, it's really best used as a screening test during health to understand our risk of exposure, right? To understand if there's any positive antibodies in there, that our tick preventive protocols are inadequate, that we know what is in our area, right? What our dogs are at risk for, what we're at risk for, right? Because they're showing those antibodies from infection. But it's really can be tricky in the face of illness, because it's much more likely that you'll have Anaplasma antibodies from previous infection than to explain the acute illness you're seeing now. PCR testing is the appropriate thing to do in the face of illness. So we have an extensive tick-borne disease panel that we can run at Antech Reference Labs. So just like we applied the expanded PCR panel for the GI parasite screening, we have an extended vector-borne disease PCR panel checking many different infectious agents because, on those serologic tests, right, we are only checking for like 3 of the major categories, right? But there are many more infectious agents. And so with PCR, we can amplify and look for very sensitively many other infections, because anytime that they're positive for one, there could be a co-infection, right? And in this case, he did test positive for Anaplasma falciparum on PCR. Fortunately, our infectious diseases with these tick-borne diseases do treat readily with doxycycline, sort of regardless of which it is, which is nice. Anytime we have any evidence of tick-borne infection, we know we need to speak of having better preventive protocols, right? And then to recognize these classic changes with acute anaplasmosis we see over and over again. We have that low reticulocyte hemoglobin, right? If you have an analyzer that will report that, like the HT5+, it is showing the body's sequestering of the iron, so it's not available to the infectious agent. We'll only see it during the time of acute infection in this case, and that gives us a heads up. We see that stress response, right, in the leukogram with the lymphopenia and eosinopenia and the classic thrombocytopenia. The next case I'll talk about is Blondie. Blondie's an 8-month-old female spayed lab mix. And she has a history of suspected fabric ingestion from tearing up some toys that came in her new monthly subscription to a bark box. So I don't know if that's something that we have over here, but in the United States, some spoiled dogs at home. She belongs to a single young gentleman, and Blondie's his whole life. So he adopted her as a young puppy. He works from home, so they spend a lot of their time together. And he gets this monthly subscription of this bark box because it keeps her busy, as he takes a lot of his phone calls and meetings at home. Well, he opened the new bark box, and he opened it that day as she was playing with them. He was taking his calls. And when he went to check on her, she had been quiet for a while, so obviously it kept her interested. But he noted that one of the fabric toys had been torn up. Right now, we tried to sort of put it back together to imagine if it was whole in the pieces that he had, and it looked like pieces were missing. So he was concerned. Initially, she felt fine, but over the next couple of days, she started vomiting. So she vomited even though she was still eating, right? She was still bright. She appeared non-painful, otherwise seemed okay. But of course, he's concerned, is that fabric in there? So he went to his regular veterinarian. He is concerned about finances, and while they had offered a lot of different diagnostic options to look into if that fabric could be ingested, they had settled on treating her empirically for just a gastritis, given that she was non-febrile, non-painful, and still eating and bright. So they treated with an antiemetic and some sub-Q fluids. He was initially encouraged, but within 12 hours after returning home, she started vomiting again. And then she got more lethargic, more depressed, and seemed a lot more sick now. So by the time he's presenting at our hospital, he's very concerned and she's more sick. In physical exam, she was noted to be lethargic. She has tacky mucous membranes as evidence for her dehydration. And she was tense on abdominal palpation, so it was hard for us to assess pain or not. When we look at her CBC, and in this case, I'm going to run it on the HT5+, another in-clinic analyzer through Antech. When we look at her results on the HT5+, and we look at the leukogram, right, we know she has a mild leukocytosis with a mild neutrophilia and mild monocytosis, right? So they are mildly elevated, but do appear to support inflammation. And more importantly, we're going to look at the cytograms that are paired with that data. So I've highlighted here in yellow this box. It's called the DIF3D. This is a graphical depiction of the cells, a scattergram. That's what they're called. We see all those little dots, right? That's a reflection of the white cell differential. So this white cell scattergram is generated from a flow cytometer within the analyzer. What's happening is that the cells are introduced rapidly and individually through that flow chamber, right? And they go in front of a laser light. And then once they come in front of the laser light, it scatters the light at different angles, right? And then we can capture that scattered light to read a fingerprint, if you will, of each cell. right? And so what's interesting about this analyzer and adds some additional benefits is that it also uses fluorescence as part of this algorithm to figure out who the cells are and pathologic changes, right? That fluorescence is generated from a fluorescein stain. So within the analyzer, a fluorescein stain is added to the blood sample. That fluorescein stain will intercalate into nucleic acids of the cell. So the nucleic acids meaning the DNA, so in the nucleus, right? But also into any RNA, right? In the cytoplasm. And so as cells coming from the laser light, right? The laser light shines, we capture the scattered light. We'll capture a couple of things. One is the fluorescence level. And then we'll also look at a side scatter that's generated from complexity or granularity of the cell. And we're going to graph those results, those two coordinates, right, of a certain amount of light, right? We'll use those coordinates to graph each cell here in the schematic that I have. So in this graphical depiction, you'll see that we have that granularity there around the x-axis. And on the y-axis, we'll have fluorescence, right? So lower fluorescence at the bottom and higher fluorescence at the top. And so as the blood cells, in Blondie's case here, coming from the laser light, right, it's looking at tens of thousands of cells, right, and it plots them on this graphic. So very rapidly, right, in under a minute, we're going to get this graphical depiction of the cells that is generated. And the analyzer at that point is just objectively plotting them based on scattered light and fluorescence. And then it will go in afterward, right? And it knows where healthy cells live in this graphical depiction. So it'll color them appropriately, right? And then we can use this guide I have, here that will tell us where the neutrophils are, right? In the turquoise dot at the bottom. And then we have the cloud of the green, that will be the lymphocytes. We have the monocytes in pink, the eosinophils are over there in red. And then the blue, we don't have to worry about the blue at the bottom. Those deep blue ones, that's unlysed red blood cells, and they're never important in us figuring out what is going on with these patterns. So what's really important when we have data from these analyzers and we have these graphical depictions of cells is to use them through pattern matching, right? So get an example of normal from a healthy dog or healthy cat, right? A species match normal. And if we look at Blondie's scattergram, her white cell scattergram, and compare it to a healthy dog, right? It's pattern matching and we see a significant difference, right? So in the healthy dog, we appreciate here, circled in white, right, that we have where the normal mature neutrophils live. But if we transpose that onto Blondie's graphical depiction, right, her scattergram, we appreciate there are no normal, mature, segmented neutrophils, right? There's an absence of cells in that space, and instead they're up higher on that y-axis, right? And that tells us, remember, about fluorescence. And so when we see that turquoise cloud higher like that, that increased fluorescence tells us that the cells have either a bigger nucleus and or more RNA. We see more RNA when they are younger cells, right, or when they're activated. And so seeing neutrophils, right, that have a bigger, puffier nucleus, right, that are younger, that's an indication of bands or metamyelocytes. Right, so seeing those high up there on the y-axis, that lets us know she has a significant left shift. And that's the best way to recognize inflammation. So this is a significant change in our cells, and it will do a lot better looking at tens of thousands of these cells that are graphed here than you or I could do looking at a blood film and trying to quantitate the bands. So we see, and are concerned, as is Dad now, that she has significant inflammation with this left shift, and we also are worried about her GI tract and possible foreign body ingestion. So the analyzer does help us with some flags. There's abnormal morphology flags. So we appreciate up here on the top, we see that we have the white cell messaging, right? And it does say band cells suspected, right? So until you learn those cytograms, we are guided by some of these flags that will help us recognize that morphologic change. So having a band flag is very helpful in recognizing our sick patients. Now, if we want something more objective, right, a number to put on this inflammation, we can use acute phase proteins. So acute phase proteins are plasma proteins. They will increase or decrease by 25% during inflammation, right? It's because those inflammatory cytokines that go to the liver that cause the production of these acute phase proteins that we can measure in the plasma, right? They're not stored in the body, so they come up with inflammation and they go down as inflammation subsides. You're probably used to looking at albumin and understanding that in looking at your chemistry profile in a sick patient who's hospitalized with inflammatory disease, we'll often watch their albumin level dropping, right? That's because it's a negative acute phase protein. It's going to decrease by 25% in the plasma during intense inflammation. But what's equally exciting, probably maybe even more so, is to measure the positive acute phase proteins. And so for different species, it's a different acute phase protein that tells us more about their inflammatory state. And for dogs, we generally use CRP, C-reactive protein, and for cats, we use serum amyloid A. So major acute phase proteins are the ones that we want to measure because they're going to change more than tenfold, so they're more easy to detect. So CRP in dogs is used to detect that systemic inflammatory process, right? Give us an objective measurement, so it will characterize the severity of that, and then allows us to monitor it, right? So the value comes in not just recognizing the inflammation, right? But once you've invested in getting that number, right, is to repeat it during treatment to make sure you're on the right track and no complications. So CRP, right, it comes up rapidly in this, we can see in the graphical depiction here, IL-6 injected in that study, they watch the CRP rise very quickly, right? And then cessation of the IL-6 injection and the CRP drops really quickly in the plasma. So it indicates the current situation. So it really is most effective used in the point of care setting because finding out tomorrow about today's inflammation is really not that helpful. So it's a useful patient side test. And trending, again, lets us know we're going in the right or wrong direction. So we use them in practice to establish the diagnosis, right? Understanding that the white blood cell counts, like in Sammy's case, right, don't always show the classic inflammatory leukogram. We can trend that data in response to treatment, make sure they're not developing any complications. So sometimes we'll look at these post-operatively, right, and make sure that there's no dehiscence of a resection and anastomosis, et cetera. And I'll show this example here. So we have a graph here from a study that's looking at a cat presenting with pancreatitis to the hospital. And so what we have here in the black boxes, right, is looking at the SAA, serum amyloid A, acute phase protein in that cat during treatment. I'll tell you clinically, the cat improves each day during treatment, and the serum amyloid A dropping on that graph there with the black squares, right, that is showing that appropriate response, that trends, right, with her clinical picture as the SAA decreases. But the white circles, right, the open circles in the graph that are rising across the days of hospitalization is actually her total white cell count, right? So the white cell count is rising because of sort of this chronicity and the bone marrow catching up with that inflammation even when it's starting to subside. And then we're also looking at the pancreatic lipase with the open triangles. It's also rising during that time, right? It's lagging based on her clinical signs and actually her pancreatitis is getting better, right? We know that those acute phase proteins are going to be a better, more objective measurement and easier to trend. So we looked at CRP on Blondie, and that's a test that we can run on the Element I+ in clinic. We'll see that the C-reactive protein did indeed come back significantly elevated, right, at 18.7 mg per deciliter. So we then go through the rest of her minimum database, right? We look at her chemistry profile. Unfortunately, despite having the significant inflammation and some vomiting, there are no changes through her chemistry panel. So we appreciate that for two reasons. One is to make sure we're not seeing any other cause for vomiting, metabolic, right, and origin or renal failure, something like that. We also appreciate she has no significant electrolyte disturbances at this time. So we also are grateful for that. And that as we think about possibly a dog who may be surgical, it's nice to use this as a pre-anesthetic screen, right? That liver and kidney function's appropriate. When we look at her abdominal radiographs, right? I'm just showing one view here, but there are some gas patterns. There is some concern in the cranial abdomen, maybe about foreign material, but no overt obstructive pattern, right? It wasn't quite clear to the clinician on the case, right? Concerned about those patterns, possible foreign material, but no overt obstructive pattern that gave her the confidence to know for sure that we had to take this dog to surgery. So she did submit them for a radiologist review to get their specialized opinion, and they did say there was a suspected mechanical or partial obstruction, and they were specifically concerned about a linear foreign body. They went so far as to say, yes, consider surgical intervention was just what she needed, right, to actually take this dog to surgery with some confidence, but also, given the description, to know what she might find when she was in there. Because indeed, interestingly enough, when she was going into surgery and she was getting intubated, they noticed that she had a laceration under her tongue, right? And so that laceration, which we commonly associate with cats who eat strings, right, and get tied under the tongue and create that laceration. It was the first time I had seen it myself in a dog, right? And while there was no string attached in the mouth anymore, it had us concerned that we'd find that further down in the GI tract. And indeed, she did at surgery. So the extensive surgery notes, which is never a good sign for the pet, but it said a foreign body found in the proximal to mid-jejunum, anchored to more foreign material in the stomach with an extremely tight string. So that caused a plication of the duodenum and the mid-jejunum because of that linear foreign body. There was a perforation as well as other areas that appeared necrotic in this area, and they had to do an extensive resection and anastomosis of almost a foot of bowel. So very significant disease by the time they took her to surgery. So now, while they resected a significant bit of bowel, right, there's always a guess of, are you leaving in the right healthy tissue that can recover appropriately? Have you removed everything else that could necrose or dehisce, right? And so we're always watching these patients closely post-operatively because it becomes a little bit of a mystery once you close them up, right, at surgery. And so we can use these cytograms, these acute phase proteins, to trend them very sensitively to make sure we're not seeing any complications, that they're recovering appropriately. So again, if we look at Blondie cytograms here, remember this is the white blood cell scattergram. We look at the healthy dog and then this Blondie next to it. We see, right, that's her on presentation where her neutrophils are very left shifted, right, increased fluorescence and higher on the y-axis. The day following surgery, we appreciate that those neutrophils have come down in size, right? And on the third day, even further. So if we trend that neutrophil cloud, right, from where they are on presentation too high on the y-axis, moving down, further down, and even writing that axis to be a little bit more horizontal, we appreciate that she's recovering appropriately. Also note that when she presented, right, she had an eosinopenia because she had a stress of illness, right? Less red dots. Those red dots are the eosinophils. So she has no red dots basically on presentation because she was really stressed because of the illness. As she starts to recover, we appreciate more red dots, right, on day 1 post-op and even more on day 2 post-op, also reassuring us, right, that we are on track. Now, objectively, right, beyond the scattergrams is we can use that CRP data because we get a number on that to trend. So remember, she presented at 18.7 mg per deciliter. And day 1 post-op, she had dropped down to 15.4. And even further on day 2 at 11.2, and seeing both the scattergrams going the right direction as well as the CRP decreasing, right, in number, gives us the confidence to send her home maybe sooner than we would otherwise, because we see that we're on track with those objective measurements. We feel like in trying to save dad some money, right, is that he continue, if we switch her treatments over to orals, that she could go home and finish her recovery at home, which she did uneventfully. The next case I'll talk about is Camie. So Camie's a 3-year-old female intact dachshund, or was intact when she arrived. She's 3 days post-whelping, and she had 4 live puppies. But now she's vomiting, anorexic, and lethargic. On physical exam, she is febrile at 1047 degrees Fahrenheit. She's tachycardic and tachypnic. Again, we're using the HT5+ here, and we look at her leukogram. Let's also note here, no traditional inflammatory leukogram, right? No leukocytosis, no neutrophilia. And as I said, less than 50% of cases with known inflammatory disease will have that classic inflammatory leukogram, and it does not exclude that inflammation, right? So we need to find another way to diagnose inflammatory disease. Recognizing a sick dog with that stress response is important, right? So on Camie, we recognize the lymphocytes and eosinophils. While only the eosinophils have flagged low, appreciate that both on the visual reference interval on the far right side, that they're both trended down on the low end of the reference interval, right? That's how we recognize that stress response of illness, right? Sick dog test. Now, again, remember with this flow cytometer that's inside the analyzer, right? It's using that fluorescence as well as the side scatter to generate, right, these scattergrams, right? The white cell scattergram we appreciate on the right-hand side here. And if we look at Camie's, right, and we compare it with a healthy dog, she's similarly, right, rather than having the neutrophils where they should be, right, hers are also really high up on the y-axis. Also appreciate the superimposed stress response, meaning she has less green dots, right? Green dots are the lymphocytes and less red dots, right? Those are the eosinophils. That's superimposed stress response. Also, this did give us a flag on the HT5+, so until you learn those cytograms, we have some helpful interpretation where band cells suspected did make the flag from the analyzer, letting us know she has a significant inflammatory process. Now, if those are you who may see scattergrams because you've had the ProCyte DX in your practice, right? Note it's a little more confusing on the ProCyte DX. It's a very similar scattergram, right? Generates still from fluorescence and side scatter, but the cloud of neutrophils is actually being mislabeled here and miscounted as lymphocytes and monocytes. So the colors are wrong. So it's in this similar place on the graphic, but it means that the analyzer is going to be reporting them not as neutrophils as they do the HT5+, but in this case, as monocytes and lymphocytes. So just be cautious if you're using this analyzer in practice. Just recognize that when those cells have found themselves in another position, right, on the graphical depiction in these scattergrams, right, the analyzer is going to be confused at who they are, right? So it's a little tricky. We look at a blood film for confirmation. This will be especially important if you have the ProCyte DX because, again, it's mislabeling those cells. So you're going to look at a blood film to say, are those truly monocytes up there? You'll recognize that no, instead, there are these toxic bands, right? So toxicity, right, is something that we see in the cytoplasm of cells, right, in circulation. So we recognize them as some of those angular blue Dolly bodies. They have a general blue-gray background, that's cytoplasmic basophilia, as well as that foamy vacuolation in the background, right? So those are signs of toxic change, which supports the systemic inflammatory process. It is very commonly related to a gram-negative bacterial infection, right? That should be top of mind. Other differentials in a dog would be severe canine pancreatitis or fulminant autoimmune disease, right? Those are some of my top differentials for when I see toxic change. But usually, most commonly, it's often from GI flora, your gram-negative bacteria that have translocated elsewhere outside the GI tract. So either through a damaged GI wall, right, through the mucosa and into the bloodstream, right, or it may ascend to the liver and create a hepatitis. It may ascend up the urinary tract, right, and then create a pyelonephritis. It may ascend up the genital tract and create a pyometra or a prostatitis, right? Or they could vomit and inhale, right, and aspirate, and in which case you might see it as a pneumonia, right? But those gram-negative bacteria, which when they're in the GI tract are sort of outside the body, right? And they're not seen by the immune system until they translocate out of the GI tract. So we did some imaging on Camie. They first want to make sure that there were no retained puppies and there's no fetal skeletons in there, so that's good. But they did detect a significant amount of ascites, right? So what we see here in that area with the ASC on there, that is ascites, a pocket of fluid, right? So we sample that fluid and make a cytologic preparation. We realize there's tons and tons of neutrophils, right? These neutrophils are very degenerate. There's some macrophages in here, and if we go in closer here, we'll appreciate that we have some intracellular large rod-shaped bacteria. So Camie has a septic abdomen. That's going to be a surgical process. So she went to surgery. They found green fibrinous and mucoid material throughout her abdomen from a ruptured uterine body. Yikes, that must have happened during whelping. So she was spayed. They added one of those Jackson-Pratt drains to drain the abdomen and get that septic effusion out continuously after surgery. And then she was monitored postoperatively for a few days. We can trend that inflammation. Looks very similar to how we saw it in Blondie, right? Where each day we appreciate that while she starts with her neutrophils very high up on that y-axis, each day they come down, and further down, telling us she's recovering uneventfully. We also appreciate she presented with no eosinophils because that's stress response, and they start to come back in low numbers and more significantly on day 4 postoperatively. The next case I'll talk about is Bella. So Bella's a 7-year-old female spayed Labradoodle. So Bella has a history of seizures. She had not had seizures for a couple years since being loaded on her phenobarbital, but then she did have a couple breakthrough seizures on a particular weekend. They had called into the hospital. They okayed them increasing her dose of phenobarbital and scheduled a recheck appointment. When she came in for this recheck appointment, I think that they felt, considering she had had no more breakthrough seizures, that she may just get sort of a wellness check and a refill of her phenobarbital. But they noted a few things. One is she had had some weight gain, right? An objective measurement that we get at each visit so that we can detect these changes. They didn't appreciate at home. We also had seen since our last visit, she had some hair thinning over her dorsum. And when we talked to the owner, actually the technician did a wonderful job, right? Or nurse, as we say here, did a wonderful job of asking open-ended questions about what they were seeing at home with Bella, what her days looked like, what her activity looked like. And they ended up mentioning that she was drinking more and peeing more. She was polyuric and polydipsic, PUPD, right? And this was a new finding. And as they talked about it, the owners were not concerned though, because they said, we remember when we loaded her on her phenobarb initially, she also exhibited this polyuria and polydipsia. And they thought because she had increased her dose, right, that she was just a response to that phenobarbital. But putting that together with some of her physical changes and some of these breakthrough seizures, the clinician on the case thought it was best that we run some lab work to make sure nothing else was going on. So they started with drawing a CBC in chemistry and drawing that blood and submitting them to the lab. And then they went to ultrasound to do an ultrasound-guided cystocentesis to gather a urine sample. Now, this is where my desk used to be in the ultrasound room, right? And so I'm actually right next to the table here where the patients will be for the ultrasound-guided cystocentesis, right? And so I was hearing a little bit about the case. And I heard the clinician telling the nurses telling the clinician about some of the history. He's just doing a brief caudal abdominal ultrasound to get urine, but he's pausing for a long time. And there's a lot of him and hawing there. And he is unable to visualize the bladder. Right? And that's really unusual, right? This is one of our more senior clinicians. He does this every single day in getting part of a minimum database for a patient. And so curiously, using my computer here, I had looked up her case, just wondering what could be going on. And I had noticed that we had captured a picture of her urinary bladder. It was saved in her record from her previous visit about 3-4 months previously. And so I know that she didn't have like a pelvic bladder or something that wasn't able to be imaged. Right? And he was frustrated as well. He couldn't figure out why he couldn't see her bladder, but he figured she must have urinated right before coming in the hospital. And unfortunately, we weren't going to be able to get a sample. The technicians and the nurses were getting her down off the table. And I just thought, oh my gosh, can we have a patient who presents polyuric and polydipsic and not even get the urine specific gravity from this dog, right? It would be such a miss, because how would we know if she's dehydrated, if she has an azotemia? Right? Is it because her kidneys aren't working, or is it just dehydration? So I said, would you allow the technicians just to take her for a short walk? And even if she squatted to mark, right, with urinary marking, that if we got a few drops of urine, it could be really useful in our diagnostic testing. So the clinician agreed, and the nurses take her out for a walk. And then they call me to the lab moments later, and they said, this is her urine. They said she had urinated such a large amount. This is not even all of it. Right, that she had squatted urinate as soon as she went outside. And she obviously has this pathologically bloody urine, has clots in it, as we can appreciate. Right, so we called the clinician into the lab and said, this is Bella's urine. And he said, like, Bella, the Labradoodle with the seizures. And he's like, what's going on? Like, he really had looked for her bladder and didn't appreciate it. So he asked them to take a lateral abdominal x-ray. And we can even see, even after that urination outside, that she still has a distended bladder. Right? Or at least a detectable bladder, but it looks really weird, right? So there's increased opacities there in the bladder. And I don't know if anyone had seen this before, but we hadn't at our practice, right? So we asked a radiologist for some feedback, and what they told us is this is called emphysematous cystitis, right? So emphysema, like we're talking about having gas-producing bacteria, right? So having that gas either in the wall of the bladder or the lumen of the bladder, right? So there's gas-producing bacteria in humans. I guess it's almost exclusively associated with them being diabetic. It's not the case for our dogs and cats, right? But we do think that she has a bacterial infection, right? It causes that increased opacity. And because of that change in echogenicity, it's superimposed on the surrounding soft tissues in that caudal abdominal ultrasound that he couldn't appreciate the traditional fluid-filled bladder. Okay, so now we have this urinalysis to run, right? Obviously, it's red and cloudy, as we appreciate, tons of white blood cells, tons of red blood cells, as is apparent. And I put a question mark here next to bacteria, right? So I put a question mark next to bacteria because I think it can be really challenging, right, in looking at a urine sediment to feel confident in our diagnosis of a bacteriuria. I think that we have a lot of Brownian motion in some of our active sediments, and they can look like cocci, right? I think if we have any sperm in our specimen, it can be hard to detect rods. I think is really common. And even if we use like a SETI stain to try and stain some of them, that unfortunately then we can introduce a contaminant from the SETI stain. And we find a lot that we have clinicians who are submitting samples for culture because they believe they saw something at the microscope, but the culture doesn't end up finding anything that grows. It is possible that something has died off, right, during transit to the reference lab where it's being cultured, but I think commonly it was being misdiagnosed in the clinic. So what I recommend, if that we have concern for any pyuria, especially if there's increased white blood cells, right, in the urine, is that we make a cytologic preparation from that urine, right? We treat it like it's going to be a typical stain cytologic preparation, so we recognize the bacteria with confidence. So in doing so, we spin down the sediment like we would routinely, right? Add urine to an Eppendorf tube, separate out some, spin it down routinely, decant the supernatant, right? Reconstitute the pellet. And then you're going to make a line prep that I have pictured here. So the sediment line prep, you take some of the reconstituted sediment and make a drop at the butt of the film here, of the glass slide, right? And as you push your spreader slide across the surface, rather than going all the way to the end and creating like a feathered edge, like a blood film, right? You're going to go about 2/3 the way across and then lift straight up. Right? What's happening there is that you're pushing the majority of the formed elements along the front edge of that spreader slide. So when you lift straight up, they're deposited there. Often in the urine, we don't have a lot of formed elements. They're quite diluted by the urine itself, right? And so if we just made a direct smear of this, right, it'd be unrewarding and you may not detect all the different interesting formed elements, right, the cellular components. So we make a line prep. We've concentrated them optimally. We'll stain it routinely with our diff quick stain. And then microscopically, we can look at where the arrow is, right? Exactly where that line is with great reward. And on Bella, we do that, and I've captured this image. And now it becomes very clear, right? When we treat these as traditional cytologic preparations, we now can appreciate with confidence bacteria because they stain blue, right? And we can see the shape of the bacteria more clearly. It helps us for our initial diagnostics and antimicrobial selection, right? We can appreciate whether they're extracellular, intercellular, or both as it is in this case. So we did confirm her bacteriuria. Now, as we look at her biochemistry panel, right, there's a couple subtle changes. She has increased cholesterol, and that was new for her. Historically, she had not had an increased cholesterol. And it gave the clinician some pause because as it turned out, remember I had that picture of her urine captured from 3 or 4 months ago. She had actually had a bacteriuria or UTI diagnosed at that point. And we had treated her for that UTI, but we did not recheck the urine. And so we don't know whether she actually has a persistent infection that has lasted these several months, right? Or a recurrent infection, which seemed a little more likely given these new clinical signs. And so when looking for causes of recurrent infection, we start thinking about underlying endocrinopathy, which could also maybe account for her weight gain and her hair thinning over her dorsum. And so seeing that high cholesterol, a top differential for a dog would be hypothyroidism. We also looked at an elevation of her liver enzymes, right, of her ALT and her alkaline phosphatase, right? And so seeing both of those elevated made him wonder, again, now she's on phenobarbital, right? And we look at the trends, right, of her ALT and her alkaline phosphatase, and I have them graphed here. That bottom gray line, that is actually is a box beneath that that's showing the upper end of the reference interval. So we can see that as she has been on her phenobarbital and they increase the dose, we can see the ALT has been gently rising. But we notice the alkaline phosphatase, that one jumped more, right? That jumped more recently. And so that more recent jump in the alkaline phosphatase and trending that had them wonder, could there be underlying Cushing's? Could that be her recurrent infection? Her hair thinning over her dorsum, her weight gain? That came to mind as well. Cholesterol, again, as I told you, was a new finding. So again, the gray box there is the reference interval. Historically, she had been within the reference interval, and now she's first coming out. Again, early indicator of hypothyroidism. That was one of their questions. So now it becomes a little more sorted. Remember, they thought they were coming in to just really get an exam and a refill on their phenobarbital. But with this increased seizure activity, right, and some physical changes, and then we look at the lab work a little more critically. We know she has a bacterial cystitis. Does she have underlying endocrine disease, right? The hypothyroidism or the hyperdrenocorticism. And, when we're struggling with questions like this, right? Do we run T4? Do we start that as a screening test for her thyroid testing? Even though we're in the face of illness, right? That's a little challenging to get an accurate read on the thyroid activity. Do we start with a low-dose dexamethasone test for her Cushing's? And when you're grappling with these, do not hesitate to reach out to the consultation services at Antech. They are a wonderful team of over 150 board certified specialists in almost every single specialty. Obviously, the majority are in internal medicine. They love helping with cases like this, and they can give you a nice fresh perspective on putting the data all together. And they were very helpful in Bella's case. So they reminded the clinician, let's first focus on the known problem, right? She is presented for polyuria and polydipsia, right? And we have a reason, right? It may not be the whole reason, but she has a bacterial cystitis that is known. Let's focus first on treating that, right? Because if we can treat that and get that resolved, we'll have a much more reliable test of her endocrine system, whether you're testing for hypothyroidism or testing with a low-dose dexamethasone. We'll interpret those results more clearly when there isn't concurrent disease. So treat for that first. If she remains polyuric and polydipsic, now we can do a workup for her Cushing's, right? Then we could do the low-dose dex. Now, as far as testing for a thyroid, right, the internist reminded them results will be affected by being on the phenobarb. So we actually can't test a T4, even a free T4, even TSH can be affected. So unreliable test and not worth the money in the face of this. But it may be worthwhile to get a phenobarb level, right? Request that from the reference lab so they know whether she's on the appropriate dose, given that she's had those breakthrough seizures. The next case I have is Charlie. So Charlie's a 4-year-old female spayed lab. And Charlie, of course, not a typical female name, but a really cute story for her. Her parents had moved the family clear across the country. They have 3 young children. They were not upset about leaving their friends, their young school-age children. It wasn't the friends. It wasn't moving away from family. It was that there was a neighborhood dog, Charlie, a male lab who would hang out with the kids at the bus stop, visited everyone's home in the neighborhood frequently. They sort of thought Charlie was theirs. And when they moved across country, they were super, super sad to be leaving Charlie. So quickly after arriving in Pennsylvania, where we live, they got themselves a yellow lab, even though it was a female, but named her Charlie. So we are seeing her now a little over a year after arriving in Pennsylvania, and she's presenting quite ill. So over the 4 days leading up to this visit, she's had a progressive hyporexia. She developed diarrhea. It can be challenging, right? Because when she's not eating as well, then they start offering her treats and incentives. So then when she develops diarrhea, it's because of the increased treats they were giving. Then when she's eating even less, because her GI tract's upset because of what they gave her, or a pancreatitis, or is it progressive illness, right? They really weren't sure. She was getting a little weak in the back end. She didn't jump on their bed the night before this presentation when she always sleeps with them on the bed. And at that point, they said something's really wrong. On physical exam, she's obviously lethargic. She was dehydrated as well. When we look at her CBC, we appreciate that she is anemic, right? A hematocrit of 30, so a mild anemia. And she has a thrombocytopenia, right? And the estimate came from the reference lab. So she had been actually the afternoon before at the emergency hospital before coming to us the next morning at our hospital. So they had started lab work that was sent to the reference lab. So this first set of data are coming out of the reference lab. So in this case, we can verify that thrombocytopenia as they had done for us at the reference lab. In her chemistry profile, she has a reported hypoalbuminemia, right? And it's always important when we're looking at the albumin, right, that we compare it to the globulin levels. We consider those together because we want to know if the albumin's low, are all the proteins low or just the albumin? And we can appreciate here, right, that it's her albumin that's selectively low because her globulins are actually at the high end of the reference interval. So she has a selective hypoalbuminemia. She also has an azotemia. Now, we're not surprised, right? She's clinically dehydrated, right? So this may just be a decreased glomerular filtration rate because of her dehydration, right, and her hypovolemia, right? Or it may be that she has kidney dysfunction, and we need the urinalysis to figure that out. So we added the urinalysis to that lab work for more answers. So first, we'll note that her urine-specific gravity is 1025, which is inadequately concentrated. Right? Given that she's azotemic, we would love that specific gravity to be greater than 1040, right? So we know that while part of her azotemia is pre-renal because she's dehydrated, she has a renal component to that azotemia as well, right? The kidneys are not functioning well. Other changes in the chemistry, right? The urine chemistry. One is that she has a significant amount of protein, 3+ protein, right? And that elevated protein, remember in our interpretation, we always want to figure out if that protein is coming from the kidneys, and that's why we're seeing it in the urine, Or is there something happening in the bladder, like a cystitis, that could be contributing, right, to that protein? And in this case, we look, there are no increased red blood cells. There are no increased white blood cells, right? So we do think that protein is truly coming from the kidneys, right? So she has protein loss through the kidneys. Interestingly, she also had a glucoseuria. And if you, I showed you that chemistry only briefly, but her blood glucose was right there in the middle of the reference interval. It was not elevated. And if we think about how glucose is handled through the kidneys, right? So glucose is a pretty precious constituent of the blood, right? Because obviously all our cells need the glucose, in particular our brain, right, to keep us functioning. And so the body does a really good job of keeping glucose in the body. So glucose is freely filtered through the glomeruli of the kidneys, but then in the proximal tubules, it's almost completely absorbed, right? So we reabsorb almost all the glucose that's lost through the glomeruli, right? So that we can make it available in the bloodstream for the cells that need it. Interestingly, there's a threshold to that reabsorption, right? As we know patients who become hyperglycemic. So whether that's a diabetic dog or cat, or maybe a stress hyperglycemia of a cat where the glucose shoots up high temporarily, we will exceed that proximal tubular glucose reabsorption. So in the face of a hyperglycemia, we can get some spillover, right, into the urine itself. But in Charlie's case, she has no hyperglycemia in the blood. So the only reason to get increased glucose in the urine would be that those proximal tubules are dysfunctional, right? So we have concern for those proximal tubular dysfunction, both when they're not concentrating appropriately. We know we have another hit on the kidneys that there's protein loss through there. And now again, a further hit to say that the proximal tubular dysfunction, right, is leading to this glucoseuria. Also note that in her urine sediment, she has increased number of casts, right? And we separate out hyaline casts from non-hyaline casts. Because hyaline casts, when we detect them, and it's hard because they're very faint, and we often, when we're looking at the microscope, will sort of burn through them if we don't have the condenser let down low enough and the light down low enough. But hyaline casts are just aggregates of protein, of that TAM horsefall protein from the tubules. And that can occur because of just dehydration. And once the patient's rehydrated, they'll wash through. But non-hyaline casts are cellular casts, right? And so they mean that either red cells or white cells or tubular epithelial cells, right, have found their way into the tubules themselves, have aggregated onto that Ham-Horsfall protein, right? And then again, with some hydration, they're washing through. So whenever we see casts in the urine, right, what an opportunity to understand injury up in the kidneys, right, for these non-hyaline casts. And we used to think among the various casts, right, whether we have granular casts or waxy casts, we used to think like the waxy casts were worse, meant worse damage in the kidneys. That's not actually the case. Those casts sat in those tubules longer to get that more aggregated appearance, right, before they washed out. So we know that these cellular casts are evidence for injury up in the kidneys. We just don't know whether it's reversible or not. We look at Charlie's urine sediment. She has a variety of different casts. There are cellular casts that have been broken down, so they have the increased granularity to them. On the far image, we appreciate that there's that waxy cast with that real concrete formation there. So she went to imaging, see if we can explain some of what's going on, right? On radiographs, no significant abnormalities, right? So things that they had been considering given her GI signs and lethargy in a lab, right? GI foreign body, pancreatitis, like none of those changes. On ultrasound, the pancreas looked fine. There was no ascites, but with the kidneys, there was, as we can picture here, and it's a subtle change, but increased definition at the corticomedullary junction. So we can appreciate it's just a little brighter white at that junction. It's something that I would not have picked up on, but our radiologists let us know that they see that as a non-specific sign of inflammation. So we think that Charlie has acute or acute on chronic kidney injury, right? It hadn't been diagnosed previously, but we can't exclude the possibility that there had been some chronicity that got exacerbated recently. So we think through our differentials, right? Some of our top differentials, we always have to think about a toxin that could injure the kidneys. We talked to the parents and thoroughly felt that there was no risk of exposure. You can never say never, but toxin was low on our list. The next differential we considered was a pyelonephritis, right? Now we had looked at urinalysis and we did not see any white cells. We did not see any bacteria. And while ideally, I guess we would culture it to know for sure, there was no evidence for pyelonephritis. Pancreatitis can cause an AKI, an acute kidney injury. No elevation of her pancreatic enzymes. We know that those can be sometimes nonspecific, but ultrasound of her pancreas also was normal, did not show any pathologic changes to the tissue, so pancreatitis was off of our list. AKI can be caused by Addison's. An Addisonian patient could have hypoadrenocorticism, right? And that can result in that volume depletion that can lead to an AKI, so that was a possibility. Leptospirosis, especially with that glucosuria, right? That's something that those leptospires they sort of corkscrew into the kidneys and create a lot of tubular injury. Sometimes we see a glucosuria with a leptospirosis, so that is possible. And then other glomerulonephritis, right? So in our area, we worry about the membranoproliferative glomerulonephritis that happens with Lyme disease, right? So we talked about actually one of the first cases, right? We talked about a possible Lyme nephritis. So in working her up for Addison's on the Element I+, we have an option at point of care to run her cortisol level. So we check a baseline cortisol, right? Knowing that a resting cortisol of greater than 2 micrograms per deciliter would essentially exclude hypoadrenocorticism. Now, if that baseline reading comes back as less than 2, right, we cannot assume that the adrenal glands are not functioning appropriately. We have to do the ACTH stimulation. And so while one could imagine that a dog in the hospital who's been sick for days should have a high resting cortisol, right? The stress of that illness and that hospitalization. I have been fooled before, especially in young dogs, where they'll come in, I would expect them to be stressed, their cortisol level baseline will be low, but we stim them and they stim up very high, meaning an appropriate response to the adrenal glands once stimulated. So check your baseline, right? If low, you have to run the ACTH stim. If already normal or elevated, greater than 2, then you have ruled out Addison's. In this case, her baseline cortisol came back nice and high at 10 micrograms per deciliter, so we had excluded Addison's. For her leptospirosis, now fortunately she was vaccinated. So they had come from the upper western part of the United States. And so in that area, well, we see leptospirosis throughout the country and really throughout the world, right? So they had been vaccinated for leptospirosis. They hadn't been vaccinated for Lyme disease when she was in Washington State, which is unfortunate because she's been almost a year in Pennsylvania, so that was a little bit of a concern. But lepto was unlikely with vaccination. It didn't make it impossible, but unlikely. Because leptospirosis is a zoonotic concern, right, both for her family, but also for those of us who are handling her urine specimen, right, in the hospital. We did send off for PCR for confirmation, right? We couldn't check antibody levels, right? We couldn't check a titer for that because she had been vaccinated, right? That could interfere with some of those. And also when we check titers, right, we have to check the current titer and a titer like 10 to 14 days later. So PCR, because we were pre-antibiotics, could be the most sensitive measurement. And we don't know if they have leptospirosis when they were infected, because they first get infected through the blood. And then at about 7 to 10 days, the leptospires will, corkscrew and get into the kidneys, and then we'll catch it in the urine. So we don't know which is the best specimen because we don't know the time frame of infection, of possible infection. So we send off both blood and urine. And fortunately, in her case, they both came back as negative for leptospirosis. And while good that both of those are negative, that leaves us wondering about her glomerulonephritis. Right? So as we work that up, one thing we can consider is to quantitate that protein we saw in her urine. So urine protein to creatinine ratio lets us assess how significant the amount of protein is relative to the concentration of her urine. We ran her UPC, requested from the reference lab, and it came back at 3.6. And so for those of you not used to running UPCs, know that this is quite a high number, right? At 3.6, knowing that greater than 2. So anything greater than 0.5 is significant protein loss to the kidneys. Generally thought to be tubular until you get over 2, right? When the UPC is greater than 2, it's almost always larger protein loss through the glomeruli specifically, right? That's where the larger protein loss can occur. So she's had multiple hits on these kidneys, right? We did check her for vector-borne disease screening and say, well, we have to use this with some caution in the face of illness, right? We talked about that with anaplasmosis, right? For Borrelia burgdorferi or Lyme disease, when we see them with active infection, they already have enough antibodies to show a positive result, and indeed hers did, right? Which is really unfortunate because when we think about her glomerulonephritis, right? In her case, it's created a protein-losing nephropathy. Remember on her initial lab work, she had a hypoalbuminemia, a selective albumin loss, right, with significant protein in the urine, so protein-losing nephropathy, with enough damage to the tubules, right, that she's developed an azotemia, a renal azotemia, where she cannot concentrate appropriately. When they have this glomerulonephritis, it's attributed to some sort of chronic antigenic stimulation, right, that the body is a robust immune response, so it makes antigen-antibody complexes, and they end up clogging up the glomeruli and injuring, right, the glomeruli and the tubules in the kidneys. Right, so it's accumulation of antigen and antibody complexing. So it is a chronic immune response that we see. So when we think about, in our area, Lyme disease is almost the most common one implicated. In areas that don't have Lyme disease, I think immune-mediated polyarthritis is a common cause. So other causes of chronic infection, imagine some Ehrlichias would be possible as well. Okay, so in summary, when we use our diagnostic testing, right, to get objective information, right, for our pets so we can make more accurate diagnoses, right, what helps about starting these workups in clinic and maximizing our in-house diagnostics is that we can take the owner along the diagnostic journey, right? If we can review the results with them in time rather than calling them the next day, when we review them in time, we really show the value of those diagnostics. And if we want to be considerate of their wallet and go through it stepwise, right, we can start with looking at the CBC and reviewing that data with them. There's cause for concern, add on the chemistry panel, review that data, right? It takes more time, but it shows value. It involves that client in that decision-making for their pet, right, our integral role that they play in that decision-making process. And it helps us to get more accurate diagnoses, right? What it does is that once we start to identify through the minimum database some concerns and changes, right, it prompts the ancillary diagnostics, right? So while they're there in the hospital, you're more likely to get compliance on adding on an ultrasound or adding on radiographs, right? Because they're already there in the hospital and they see the concern because you've shared the results with them thoroughly. They're getting the value out of those laboratory results. Then it often moves to imaging to get more specific information or ancillary diagnostics sent to the reference lab, right? And then to leverage the expertise that we get through the reference lab, right? We love being able to give our customers choices, right? Our clients have a choice whether to run tests in clinic or at the reference lab. And it's usually, in our most advanced cases, going to be a combination of both. So we have advanced testing through the reference lab that we can offer, but we also have access to those board certified consultant team, right, to help us through some of our most challenging cases. So thank you on behalf of Antech. Thank you all for attending this.